Hello, everyone. I'm Dr. Prageti Shubha, and today I will be talking about how to incorporate facial fat grafting into your practice, especially surgeons and dermatologists who are doing a lot of these aesthetic procedures like dermal fillers and maybe even collagen stimulators, or you're doing energy based devices and you're not getting optimal results. Also, currently, we're seeing a lot of dermal filler fatigue, a lot of patients coming back either dissolving their fillers or they are not happy with the kind of results that they have. They're not happy that they need to get these fillers done again and again. And, they want something more, something which is more long lasting. They want something which is more natural looking. And of course, expense also matters. And the learning curve for most of you who are already practicing injectable procedures is slightly lesser for facial fat grafting. So let's begin. Incorporating facial fat grafting into your practice. Now, in our facial aesthetic practice, most of us are doing the following procedures for the indications in our routine practice. We are doing a lot of dermal fillers for volume restoration and contour correction. We are doing blepharoplasty for periorbital rejuvenation, lasers and chemical peels for pigmentary disorders, non-surgical skin rejuvenation procedures, and surgical or even laser or energy-based device-assisted correction of scars, whether it's atrophic, traumatic, or acne scars. And these are all reproducible, evidence-based interventions that we are practicing today. But are you considering fat grafting in your treatment plan, either as a primary intervention or as an adjunct, or are you not considering it at all? I know for most of you, it's option C. When you get a patient of scarring, you get a patient for volume restoration, your mind straight away goes to non surgical procedures most of the time, especially in the Indian setup where patients are not very open to surgical procedures. So you're not really considering fat grafting. Now, what limits adoption? Is it the concept or is it the technique? Now, fat grafting continues to be associated primarily with volume restoration. So, whenever we think of fat grafting, we're thinking we're taking fat and we're just grafting it into the face to just correct volume or just do a little bit of filling or just do contour correction. Facial fat grafting was actually initially described by Neuber back in 1893. And then, of course, popularized mainly by Coleman in 1998, where he started talking about a structured and modern way of, not only doing fat grafting, but also how to harvest it, how to prepare it, how to deposit it in multiple layers. And so Coleman really needs to be credited with the immense work that he's done in facial fat grafting and how he has popularized it. So, what is the biological basis of autologous fat grafting? Now, autologous fat is not an inert filler. It's not like a dermal filler where you have hyaluronic acids which are cross-linked. But here, adipose tissue actually represents a composite graft, right? It's composed of structural elements, which is where it becomes important in volume correction and contour correction. Also has a lot of regenerative elements which help us in, again, skin rejuvenation, hyperpigmentation, and also scar management. So, contemporary evidence demonstrates that adipose tissue possesses proliferative as well as reparative potential. A substantial proportion of the cellular population is derived from stromal and progenitor components. Now, when we are going to harvest adipose tissue, what is the cellular composition of it? So it contains, of course, the mature adipocytes, which is the volumetric element of it. It has an extracellular matrix scaffold and it has stromal vascular fraction. When you're talking about stromal vascular fraction, this is what represents a heterogeneous cellular population. One of the elements of your SVF is your ADSC, or adipose-derived stromal cells. And these are those multipotent cells which are capable of proliferation and lineage differentiation and therefore contribute to regenerative signaling within the recipient tissue. So apart from ADSC, it also has endothelial precursor cells, pericytes, macrophages, smooth muscle cells, and pre-adipocytes. Again, adipose-derived stromal cells, because they are progenitor cells and multipotent, they can differentiate depending on where you're injecting them into chondrocytes, into adipocytes, into osteoblasts, into endothelial cells, myocytes, and neuron. One thing that needs to be kept in mind, of course, is that as and when we start aging, they do become senescent. So beautiful results in more younger patients compared to more older age group patients when you're talking about any of these procedures, which are your, autologous tissue being used for regeneration. So now what is the technique? There are four main components. You need to select a donor site, then you need to harvest the graft, you need to process it, and also deliver the fat into an appropriate plane, into the appropriate tissue depth. Uh, Donor site is usually chosen where there is a lot of resistant fat. So usually areas that are chosen are your abdomen, outer thighs. Those are areas where you extract fat from. Now, once you've extracted fat, depending on the indication, now there will be areas which would require larger volume enhancements. And here we're talking about larger enhancements like, let's say, a buttock lift or a breast augmentation. Here you would require larger sizes of fat, and that is what basically macro fat means, which is a particle more than 2.5 mm. Then you move on to microfat. And microfat is what we primarily use for volume restoration in the face, where the size of the particle is about 1 to 2 mm. And then, of course, you have nanofat, which is liquid emulsified particles, which is less than 1 mm. Here, they really don't have a lot of volume related effects. It's mainly for rejuvenation, right? So macrofat, about 2.5 mm for breast augmentation, buttock lifts, microfat mainly for facial augmentation, and nanofat for skin rejuvenation. Now, when we're talking about repairing these particles, of course, you get your facial fat grafting set. You don't, it's not a very expensive set to invest in. You need a few connectors. These connectors, if you can see my cursor, will have the mentioned in it, and it's just like you pass it between two syringes. You connect two Liverlock syringes with this connector, and then you pass it from one syringe to the other, and depending on the size of that connector, you get those particles, right? So again, 1.2 and nanofat. And this is what your and this is what macrofat looks like. Microfat is more liquidy, and nanofat is extremely liquidy, easily passable through your 26 gauge 1 mm tuberculin syringe. Now, application in medicine, they have a dual effect, and we've already mentioned it before. First, of course, we already know about it, is structural restoration and integration. So, reconstitution of deflated superficial and deep fat. Here, you can put in more volume of the fat, and it has a more natural contour compared to a filler. Restoration of facial convexity, skeletal soft tissue relationship, redistribution of soft tissue load across retaining ligaments. Again, your injection points in terms of where you're placing these fat grafts are similar, not exactly, but quite similar to how we're doing dermal fillers. And the benefit is, of course, long-term volumetric persistence. So because uh, like any other graft, there's plasmatic imbibition, there's inosculation, and then there's neovascularization, and that is how your graft survives. Now, this is also one of the drawbacks of fat grafting. Unlike a filler where you're very exact with, how much product you're depositing and how much result you will see post the procedure, let's say after it has integrated with your tissue. In fat grafting, it really depends upon neovascularization of your graft and how much fat survives. So there is a percentage of fat which is lost, and that is why never do you tell your patients that one fat grafting intervention is enough. The first one, of course, we do the maximum amount of grafting that is required within the limits of survival of that graft. And then after, let's say, 4 to 6 weeks, the patient needs to come back to you again. And if there is amount of, volumetric imbalance, or there's still a volumetric defect, then you need to go in with another session of fat grafting, or maybe a third session of fat grafting, because some amount of fat is going to get lost. And that is one of the drawbacks, the unpredictability of fat grafting that you have to deal with. But the more fat grafting you do, you kind of are able to deal with it better. You are able to anticipate your results better. The second, of course, is biological and regenerative modulation. And this is what we are using for dermal thickness, for elasticity, for pigmentation. And that is why beautiful results in scar modulation. Even patients who have come post-operatively to you and you're doing scar management, let's say with a CO2 laser or a dermabrasion, try, start injecting a little bit of nanofat repeatedly into those patients, maybe at 4 to 6 weeks intervals. and you'll see beautiful results of, that scar recovering better, becoming less prominent, becoming more inconspicuous. So, common indications, if a patient has come to you post trauma with a lot of deflation, patients who've lost a lot of weight in an age today where people are on GLP-1 drugs, where they're losing a lot of volume, getting that Ozempic face, you cannot just fulfill it with enough energy-based devices, lasers, or cannot take care of it only with dermal fillers. That amount of volume loss sometimes does require more volume, more filling, which can again be done with facial fat grafting. Reconstruction of soft tissue defects. Again, when you're feeling, I think most of you who are doing dermal fillers, when you feel the subcutaneous tissue, and if you're not doing it, that's a habit you should do of palpating your patient's face, seeing the subcutaneous tissue, whether it's more on one side or on the other, if there's a skeletal defect, all of those things. So if there's a significant soft tissue defect, that is again something that can be filled with uh, fat grafting. Perioral and lower face volume loss, craniofacial contour asymmetry, all of these things are something that you can do with fillers. And these are just some of the pictures of our patients to help you understand what fat grafting can do. And remember, these results can never be had only with lasers, energy-based devices, or even with dermal fillers, right? Another is, of course, regenerative modulation. When you see patients who've got infraorbital dark circles, very thin, dermal thinning, scars and loss of elasticity, again, you can incorporate fat grafting, nano-fat grafting, sometimes microfat. And I'm not talking about fat grafting done alone, but if you're doing, let's say, a lower blepharoplasty for a patient, you'll see that even when you do a volume, you do fat repositioning, you've done your subciliary incision, but when you add an element of fat grafting to it, whether it's microfat or nanofat, you'll see beautiful results again. So, regenerative uh, modulation with nanofat grafting is again something that incorporating it into your bleph patients, incorporating it into your even your facelift patients is a great idea, right? Look at the scar again. If you look at this patient, we've done fat grafting here. We have done also CO2 laser. We've also done Botox. So there's always a place for all of those things. But again, look how natural that lift is in the scar when you're doing it with fat grafting. Again, look at the rejuvenation element of nanofat grafting. So again, a patient where you've done blepharoplasty, you've done maybe a little bit of a facelift, and then you go ahead and do nanofat grafting, the skin starts to really look good. It really looks rejuvenated, and the patients are always very, very happy with these results, right? Again, adjunctive integration with facelift, resurfacing, always combining it with things like CO2 laser, especially patients who are, post blepharoplasty, post facelift, or when you've done a deep resurfacing, when you combine it with nanofat grafting, it gives them beautiful results. A lot of us are just doing PRP. PRP is also great, but a step up from PRP to be able to differentiate your practice from, every other clinic which is doing just CO2 and PRP. You can add these things to your practice. And all of when you're talking about nanofat grafting, it is an outpatient procedure. It's not a very complex procedure where you would really need general anesthesia and would require patient admission. It's almost like a lunchtime procedure, right? So adjunct to blepharoplasty, facelift, scar revision. Now, what are the complications? Early on, you can get edema, ecchymosis. Infection, of course, is rare, but can happen. Fat necrosis, oil cyst formation, contour irregularities, under or overcorrection. Initially, you are a little skeptical about more how much fat you need to graft, or sometimes you have overcorrected it and the peripheral graft does not survive because it doesn't, or the core of it doesn't survive because of lack of vascularization. And vascular compromise, of course, just like any other physical embolism, like we get with dermal fillers, again, if you do intravascular injection, there's always going to be a vascular compromise. So those are complications which are a reality. Graft related limitation, as we previously mentioned, is unpredictable resorption. And this is really a variable from patient to patient, variable from your technique, from surgeon to surgeon. But the more you understand, and I think we had a wonderful lecture by Dr. Bjorn on fat grafting. When you're preparing it, when you're injecting it, you need to be aware of your micro droplets. You need to be aware of how much injection in which plane, what is your bolus amount. All of those things have to be taken care of. When we say there's a learning curve, which is easier, but there's a learning curve nonetheless. And the variability sometimes does become, also technique related, right? Another limitation, of course, is that you have to tell your patient it is a staged procedure. There will be volume loss over time. They can develop calcification and nodularity if there's an inflammatory reaction around it, and there can be donor site morbidity. Technique related, like I said, graft survival is dependent on recipient vascularity. If you over grafted an area, there can be necrosis, especially in the center of that grafting. Plane specific precision is required, and technique sensitive harvesting and processing. Again, uh, you have to be careful, like with any other procedure that you do, you have to be careful at every point, from your donor harvest station, selecting the right area, using, a cannula for liposuction from the donor site, which is not as traumatic. And causes bruising and other things where, okay, you may have improved the phase, but the patient is going to keep coming back to you with donor site morbidity. Again, how do you prepare it? How do you, how you want to keep your, after you harvested the fat, how you want to let it centrifuge, how do you want the layers to separate? All of that becomes very important. So, why should we incorporate facial fat grafting in our practice? There's immense data that is available about the benefits of fat grafting, not only in volumetric restoration, but also in regenerative medicine. So, again, I think the entire spectrum of your aesthetic practice can really, really be improved, and you can somewhere differentiate yourselves in an era where there are about, I think every other shop in your area or every other building in your area has an aesthetic clinic, which are mainly focused on non-surgical procedures. We have every specialty doing dermal fillers. You're getting dermal fatigue, dermal filler fatigue. So how do you differentiate yourself from those practices? By incorporating something which is very evidence based, which is quite safe in the right, if you've learned the right techniques, and again, enough data to back it. It's not like a new treatment like a PDRN or an exosome, which has just few years of data behind it. This is something which has got decades of clinical evidence in terms of the results that it can achieve, right? Again, if you look at also objective data, there was a study done by ISAPS, also by the American Society of Plastic Surgeons, and all of them tell you that there's an annual increase in the amount of facial fat grafting that is being done today. More and more doctors are incorporating it, more and more surgeons are incorporating it into their practice. Reasons. So, volumetric, not only volumetric restoration, but also regenerative effect, long term volumetric persistence compared to just temporary fillers. It's autologous and biologically compatible here, and wider indication range from scars to periorbital, rejuvenation to also improved skin or dermal rejuvenation. There's reduced in dependence on repeated filler sessions. Even if we talk about the financial aspect of it, when you're buying a dermal filler, it's coming at a cost to you. And I'm not talking about buying a non-FDA approved or a non-CDESCO approved dermal filler. If you're buying it from a good brand, that filler cost is coming at a significant amount for you. So even when you're doing it for your patients, just a large amount of it is recovering the amount of the filler that you've paid to the company. But here, what do you really have to invest in? You have to invest in a very good fat grafting instrument set, just adding that to your armamentarium, which is your one-time cost. And that is, I mean, that is not very significant. I think within 1 lakh rupees, you can buy everything from a centrifuge set to these connectors to the cannulas to everything comes within 1 lakh rupees. And I'm talking about if you buy it from a good company. It enhances the outcomes in facial rejuvenation surgeries. It improves tissue quality. it advances and differentiates the scope of facial rejuvenation treatments which are offered within your practice. And that is something all of us need to keep in mind. We need to advance our practices. We need to be able to differentiate our practices from people who are not as well trained as us. Right? So, what is the takeaway from this particular lecture? A decade ago, facial fat grafting was largely characterized by volumetric intent, inconsistent graft survival over under correction, and limited standardization in harvesting, processing, and placement. But today, that paradigm has shifted. You have atraumatic and very standardized harvesting techniques, which are going to help you achieve better and more predictable results. You have structured processing protocols, whether it's for microfat, whether it's for nanofat, also how to make SVF based preparations, which are rich in ADSC. There's improved understanding of the graft survival biology. Again, how does the core react? How does the periphery of the graft react? All of that is well understood. And there's recognition of the stromal cell mediated regenerative effect and plane specific compartment based placement strategies. Autologous grafting has transitioned from an empirical volume filling to a biologically informed tissue restoration. And I think that is what your biggest takeaway should be with respect to facial fat grafting. And I think this webinar is mainly focused to get your attention to facial fat grafting, to not ignore it. And you need to start incorporating this into your practice. In fact, so many patients who were coming to us even 2 years back for just dermal fillers have all advanced to facial fat grafting and are very, very happy with their results.